Good morning, one and all. We are starting our CVI on CVI instruction course. Cerebral visual impairment is a bilateral visual impairment in the presence of normal ocular examination, subnormal visual performance, with or without normal visual acuity. CVI is increasingly reported in our country due to better survival of extremely premature babies who suffer from neurological damage in the perinatal period. So it is the duty of eye professionals to learn about CVA and its habilitation strategies. So when we come across such special children with CVI, we realize that we are not adequately trained to handle their problems. This instruction course is an attempt to inspire and train ophthalmologists in assessment and habilitation of these CVA children. So let's start our instruction course. Let me call upon Dr. Gigi Agustin for the first talk. Does my child have CVI? Over to you.
Good morning, everyone. First of all, let me thank KSOS and Dr. Geeta for giving me an opportunity to talk about this topic. Does this child have CVI? So let's take few case scenario. Here is a 3-month-old baby who is not looking at the mother's face but has got some unpurposeful gaze. And another 3-year-old boy not unable to catch the ball while playing, and a 5-year-old boy who is finding difficulty to identify the parents from a crowd. Here, in all these cases, the ocular examination is within normal limits, but they still have issues with the visual function. So, what is the problem then? It's beyond eyes. It could be CVI or cerebral visual impairment. So a little bit of anatomy. We have got a complex visuomotor system, and the visual impulses reach the occipital cortex. From there, two streams are there, ventral stream and dorsal stream. The ventral stream is connected to the temporal lobe, which is the visual library or the word pathway, where the prior memories of people, objects, and routes are stored. And the dorsal stream that is connected to the parietal lobe, which is the visual map, or it is otherwise known as the verb pathway, where the 3D mental map of the visual space is created and visually guided body movements are initiated. Frontal lobe takes the decision. So, disruption anywhere in this complex visuomotor system can affect the child's visually guided activities. So what is CVI? It's a verifiable visual dysfunction specifically due to disorders posterior to the lateral geniculate body. Here the eye works fine, but the brain is not able to understand what the eye sees. So what are the common causes? The common causes, most of the children will have stormy perinatal period. Most common cause is hypoxic ischemic encephalopathy. That can happen if there is any insult during antenatal, intranatal or postnatal period. Other common causes are neonatal hypoglycemia, focal brain lesions like stroke, encephalitis, infections of brain, seizure disorders, etc. So coming to the pathophysiology, in hypoxic ischemic encephalopathy, it affects the immature blood vessels of the brain, causing reduced blood flow and focal tissue death, leading to periventricular leukomalacia, white matter, that's otherwise known as PVL. So how common is CVI in children? CVI has become the leading cause of childhood visual impairment in developed countries. In India, we have highly variable reports because not all cases are diagnosed and reported. And a study from Hyderabad recently showed CVI as the most common cause of profound visual impairment in less than 3 years of age. This may be due to better survival of the children with stormy perinatal period. And when to suspect CVI? That's very important. So if the child's visual functions cannot be explained by the ocular findings, or if suboptimal response to the treatment, like if you are correcting the refractive error and you are not getting the response as we expected. History of stormy perinatal period. All these contribute to CVI. And what are the differential diagnoses? In infants, it is the delayed visual maturation. In older children, it could be neurodevelopmental disorders, autism, learning disabilities, etc. So, coming to the clinical features, it depends upon the age at which and the part of the brain affected. So, we have to differentiate CVI from ocular visual impairment or OVI. So, unlike OVI, in CVI is an umbrella term covering a range of visual difficulties, around 60 to 80 in number. The important thing is there will be variation in visual functions. Visual function is affected due to various factors like fatigue, emotional stress, visual clutter, etc. And each visual function is affected in different proportion and in different degrees in each child, like a kaleidoscope, as you can see here. And there will be delayed visual milestones, like you should know the normal milestones, visual milestones. There may be no eye contact by 2 months of age, or no social smile by 3 months, or the patient may not be able to recognize the faces by 9 months, etc. So there can be visual field defects, hemianopias or quadrantanopias. Here you can see a child with right hemianopia. The child is not able to see the right side of the board. And also the child will be having the vision like this if there is right homonymous hemianopia while reading. And if there is inferior field defect, the child may not be able to climb down the stairs. And in central scotoma, the child may seem to look at the hairline rather than the face itself. There can be decreased contrast sensitivity, abnormal and color desaturation, and difficulty in recognizing face or facial expressions. That's another important thing. And difficulty in recognizing shapes, size, letters, line orientation, roots, etc. So another term is simultaneagnosia, where the child is unable to pay attention to several details of the scene simultaneously. Example, the child finds difficulty in identifying the parents in a crowd, like this. The child's view will be like this. And simultaneagnosia may be associated with color preference as well. The child is able to see only the red balloons here. And optic ataxia, that is another one, that is impaired visually guided activity movements. The child is not able to catch the bottle, it is overshooting. And oculomotor apraxia or apraxia of gaze, here there is inability to move the eyes from one object to another despite normal eye movements. Here the girl is moving the head, the head instead of the eyes. And if you fix the head, the child will be finding difficulty to move the eyes. And looming, that is fast moving objects may not be seen, or may appear to be on collision course when actually they are not. And blind sight, the child responds to moving toys in the peripheral field but not in the center. And light gazing behavior, abnormal eye contact, short attention span, prolonged latency for visual response, all are features. Now coming to the grades of CVI, it can range from profound visual impairment or low functioning CVI, which is easier to diagnose, to high functioning CVI, where they work at or near the expected academic level of their age group. And here the diagnosis may be difficult and may be easily missed. So coming to the ocular associations of CVI, refractive error is the most common. Then hypoaccommodation or difficulty in focusing at near. it is there in 57%. So you need to do dynamic retinoscopy in all cases. Optic disc anomalies, strabismus, nystagmus are other associations. What's the role of neuroimaging in CVI? MRI is not an absolute indication to diagnose CVI, but a report of normal brain in MRI in a child with neurovisual impairment does not exclude the diagnosis of CVI. And PVL is a strong association with CVI in children. What's the need to diagnose the CVI at the earliest? Here we are making use the principles of neuroplasticity, that is, use it and improve it. Repetition matters and intensity matters. So that's the basis of vision therapy and vision rehabilitation. To summarize, CVI is one of the common causes of visual impairment in children, and its incidence is increasing due to improved perinatal care. CVI affects the visuomotor system posterior to the lateral geniculate body, and suspect CVI if child's visual functions cannot be explained by ocular findings. And CVI is an umbrella term, and variation in visual functions are very common. To take advantage of the neuroplasticity in young children, early detection and interventions are needed to improve their lifestyles. Hence, babies with stormy perinatal period and delayed visual milestones have to be screened for CVI like ROP. Multidisciplinary approach is required for diagnosis and management of CVI, and it is the responsibility of each ophthalmologist not to miss CVI and to provide effective counseling and to set ground for further management. And in our CVI clinic, we screened about 248 children during last 18 months, and we could identify 45 children with CVI. And the most common ocular association was refractive error followed by squint. And the most common perinatal history was seizures followed by asphyxia and hypoglycemia. Thank you.
Thank you, Dr. Gigi, for the lucid presentation. Now you have heard that the CVI is a spectrum. So one end there is a group of patients who are low functioning, and the other almost completely normal children with few disabilities, few issues. So now I invite Dr. Malika Harikrishnan, Professor, Government Medical College, Thrissur, to talk about low functioning CVI. Over to you.
Good morning, one and all. We have seen that the spectrum of visual difficulties in a child with CVI can range from profound visual impairment, that you call it as low functioning CVI, to a normal or near normal visual acuity but with significant cognitive visual dysfunction, that you can call it as high functioning CVI. It is very common in our practice to see very small children with such profound CVI. Like this child finding it very difficult to focus an illuminated object. And this child not even looking at the object, lighted object. Same thing is this child also. And this child, he prefers to look at one side, and that side he prefers always to the calls of mother and recognize the mother, etc. So that is what I would like to tell you about low functioning CVI. So it is very difficult to assess these children because most of these children are not very cooperative and they are very small. So how do we assess these children with profound CVI? What to assess and how? There are so many challenges we have to face because they don't even look towards the light. So how to assess the vision? What tests to be done? And even if you test all these things, you get some inferences. How are you going to convey to the parents in a language which they can understand? And finally, what you can do for them? Because the management is very closely linked with the early intervention and special education and training. So in the history, how do you approach the child? In the history, you have to ask such questions like, does the children follow people's movement? React to someone who is approaching him? React to lights being turned on and off? Return to a silent smile? React to food through vision? React for a drink? React to reflection of themselves in a mirror? React to any and reach for silent objects? If the response to any of these above questions is positive, measurable visual acuity using preferential looking methods is likely to be elicited. And in these children, you have to ask furthermore questions like, in which location they perform best? And any part of visual field better response than others. When does the children see better? Like in the morning, evening, when he is well fed or something like that. And for how long can the visual attention be maintained? Suppose there is no evidence of vision, you should look for reflex blind sight. It is a pathway connecting lateral geniculate body to the superior colliculus. It is much more developed in evolutionarily low-leveled animals, and it usually processes movement of peripheral low contrast stimuli. It is present in ourselves also, still working when the cortical system or the posterior parietal lobe is damaged. So always you can try to make use of this system. So how do we find out that this pathway is working? There are certain clues for that. Suppose there is mouth opening when the spoon is brought towards the mouth from the side. If there is some reflex large smile silently from a close range from the mother, as in this picture, or to a smiley card. And this child, when the eye is turned to the lightened object, he will start responding to it slowly. So for all these, you have to set up an examination come functional visual assessment room. How to set up this room? This room should be absolutely clutter-free and there should be facility to change illumination. All the gadgets you needed should be kept in a cupboard like this, and only whenever needed you have to take it. And what is the most comfortable position for the child? When the child is resting and when it is well fed, resting on the mother's lap. So when a child is having very severe simultaneous nausea, you can use these tents like this, which is readily available in Amazon also and very cheaply available at home only. You can make a tent like this with a sari or a bed sheet. So during the first visit, what are the things you will assess? You should do a comprehensive evaluation, refraction and accommodation. Look for any treatable ophthalmic conditions like cataract, high refractive errors, hypoaccommodation, which is often missed, control of associated neurological problems, and also you should be able to prognosticate, because once you find out some very severe ophthalmic conditions like optic atrophy, you cannot expect more in this child. So how to assess accommodation? These are a few tips. You can observe the pupil as the child switches attention from a distant object to near object at about 20 centimeter. If the pupil constricts, it is an indication that he is accommodating. If you do the retinoscopy, and if the retinoscopy reflex changes from with to against and the pupil becomes small, it indicates that the child can accommodate. Suppose all these are not possible, what will you do? Try using some ready-made glasses of powers like +3, +4, +5, etc. And in this video, you can see the child is not responding to a lighted object, but when she is put on an accommodative glasses, she starts slowly responding. And in the second visit, you should do the functional vision assessment. For that, you use preferential looking tests, Teller acuity cards or Lea paddles. Lea paddles are better for these children because they are bigger, and the stripes in that you can compare with your finger and you can explain to the parent or the caretaker This is the minimum distance, or this is the minimum width at which the child is able to see. And also you should find out what is the facial recognition distance of the child. And another method is using puppet face, because puppet face are more acceptable for the children, because any species will recognize its own face better than the other any artificial things. So also other thing is that if you do a swirling motion, that also helps, especially in a case of CVA. Sometimes you can do better in a dim illumination. All these are not possible. What is the very minimal or very simple option? You can do a mirror test. If one does not have access to routine or this preferential liking test, you can use this. Use a simple mirror and you move this mirror to the child very closely and find out the distance at which the child recognize her own face. That is the distance, and that is the optimal distance at which the child recognizes these stimuli, the visual sphere of the child. Suppose the child is not recognizing all these, what is the other option? You can use a lighted stimuli like this. And other important thing is that you should keep the illuminated toy beside the child and watch for some time, because these children will be having prolonged visual latency. So wait for at least 30 to 40 seconds before concluding that the child is not responding. And testing visual field is also important. For that you will use puppet faces or Leavant. In puppet faces, examiner should block central vision stimuli with the help of a blackboard and then introduce appropriate size puppet faces from different sides. And the child's response to that is being watched. When you use the Leavant, the examiner should bring the light of the Leavant from behind the child and see when does the child will respond to the light. This is particularly useful for those children with very poor visual acuity. Also try doing it by dimming the room light and keep the van light very close to the face. You can do some simple methods like with the interesting toy, make it illuminated and bring it behind a cardboard and popping up from different directions and look for the child's response. And sometimes that is also not possible. Make the child uses tactile stimuli. Make the child hold the toy and use that stimuli to recognize the object. Contrast sensitivity is another important test. Usually we don't do in much in the adult cases, but children it's very important because our face is a structure with very low contrast. The recognizing faces and the expression, that is very important in the case of especially in habilitating the child with CVA. For that you will use the hiding Heidi test. So to conclude, in CVA, it is unlikely that the child has total blindness unless there is some end organ total failure. As said in the previous talk, there are a lot of neuroplasticity and you can develop on that. We need to find those suitable conditions at which these things can happen. So you should keep supporting it so that it will grow further and you can do something for them. So that's all I want to say. I acknowledge Dr. Dattan and Dr. Niranjan Pahera for their articles and useful videos. And I thankfully recognize Dr. Geeta for her videos and Dr. Sujata also for her videos. Thank you so much.
Thank you, Mallika, for the excellent presentation. Now I will be talking about our experience, that is the CVA clinic experience at Government Medical College, Thrissur. Good morning, everyone. I thank KSOS and Dr. Geeta for the opportunity. In my presentation, I will be sharing our experience in setting up of a CVA clinic at Government Medical College, Thrissur. and the challenges we are facing. So our clinic started functioning about 3 years back. CVA Clinic of Government Medical College Thrissur is attached to the Regional Early Intervention Center and Autism Clinic, which works in the ground floor of the OP annex of our hospital. So we all know that REIC is a group of specialists, including the pediatrician and various therapists who work together to detect and treat children with developmental delay. So our clinic can adopt an interdisciplinary approach because we can provide all the services the child with developmental delay requires under the same roof. So this is the center is our clinic. The same corridor itself is the office of the pediatrician and various other therapists. So any child coming to the REIC will be first screened by a pediatrician who rules out any motor or sensory issue and will be sent to the CVA clinic. But a child coming straight to the CVA clinic after evaluation will always undergo a pediatric evaluation also. So our clinic is really very simple, functional. It's located, there's enough waiting area. Inside also there is enough space for the child to move around. Then there are instruments are kept in a clutter-free environment. Mats are provided for the child to lie down. And the lighting of the room also can be adjusted accordingly. So these are the various things. Everything is kept inside the cupboard. And we have all the almost all the instruments required for functional visual assessment, but everything is kept inside and taken out only when necessary. So I'm not going into the evaluation of the child because it was taken, it was discussed previously. But evaluation in our clinic starts with a meticulous history to suspect any perinatal insult. Then the child's parents has to fill in a inventory which will tell you about the visual behavior of the child. Then a detailed anterior segment, posterior segment and refraction will rule out the possible causes of ocular visual impairment. But what we are more interested in the visual behavior of the child also. How the child is brought into the room, what is he looking at, what's the color and the size of the object the child is interested in. Is they reaching out an object like that. So these are the aspects of the functional vision assessment we are testing. That is a visual acuity in young children with LEA paddles. Then contrast sensitivity by hiding HID and also visual fields. Then we also, in older children, we also employ LEA puzzle and LEA mailbox, which tests both the dorsal and the ventral stream. So another important function of our clinic is the intervention strategies in these children. So that is planned taking into account the medical history, observing how the child is functioning, then the visual assessment, functional visual assessment, and also whether the child is having any other disabilities. Our primary intervention strategy is early intervention. We have a trained optometrist who does weekly rounds in the high-risk NICU and pick up children who can later develop CVA and refer them to our clinic. And the screen and the intervention strategy is planned according to each child. It's a separate one. There's no uniform plan like that. And it is a teamwork between the therapist and the parents. And the parents should be clearly counseled about the nature of the visual defect, the need for further visits, lifelong support, and other therapies. So in a very young child, we may start vision stimulation activities. We offer office-based therapy sessions as well as supervised home exercises. and always a regular follow-up is encouraged. So we may start in a very young child with a illuminated toy in darkness and then move on to another toy which or a card which can be used in the normal lighting. And it is always the mother's face which is the most favorite fixation target a child can have. So in some children we may be confused about whether the child is fixing or following. But using an illuminated toy in darkness and slowly moving will elicit the fixation following clearly, and which can be followed up by other toys in daylight. And all then we also have lighthouse activities which promote the coordination, hand-eye, and so many activities can be planned in the light box. Then each activity is planned to improve one fish or support one visual function. It has some intention. All activities should be intentional. Then in this in older child with inferior field defect, the girl is encouraged to move down the stairs, and boy with optic ataxia who is given exercises which improve the hand-eye coordination. But the challenges we are facing are quite sometimes very discouraging. See, this child was with severe hypoxic ischemic encephalopathy, was picked up in our NICU. We had some vision intervention therapy sessions. Then child was lost for follow-up for 1 year. Then the parents brought this child recently with almost visually inattentive child because they had gone for some other therapies. Then there is still a lot of lack of awareness about this condition. This is a 4-year-old child from Lakshadweep. She was brought here she came to us only 6 months back. Then this 3-month-old child was referred to us by a nurse who had directed her because she was not looking at mother's face. We started vision therapy sessions and she was not improving. Then the optometrist noticed certain abnormal movements in the feet. Can you see that? And then pediatric evaluation and investigations revealed a rare genetic disease due to that is progressive encephalopathy and brain atrophy. And the child continued to regress in the future visits. This is also the case of an 8-month-old child who was brought with no visual awareness. Then it was detected that he had seizures and abnormal EEG findings, which is characteristic of the West syndrome, and he is not responding. Then it may be the coexisting disorders, which may be proved to be a challenge, like this central child with hypotonia, epileptic encephalopathy. It is so difficult to plan an intervention strategy. Then this child was brought with a developmental delay. We found that the child is quite visually active but not reaching out to objects. Then pediatric evaluation indicated that she had certain sorts of diplegia and cerebral palsy, and we had included more exercises to improve the hand-eye coordination. Then this 4-year-old child with spastic quadriplegia who barely opens his eyes and is so irritated if he does so is the ultimate challenge. But all children with CVI are not the same. We did not have much hope about this 72-day-old child with severe HIE and quadriparesia and so many other factors. But she showed surprisingly more visual activity, visual interest, that is encouraging. So now I would like to share a few of the cases where we could make a significant difference. This 1-month-old boy with a diagnosis of ischemic encephalopathy was again picked up in our NICU. They started vision stimulation activities with patterned cards very early, and we were able to fixed activities started within 6 months. But the child had other challenges like seizures, but still continuation of the therapies. Now at 2 years, we have a very visually active child. Though the visual activity is very much improved, he has certain motor issues, which you can see the feet of the child, and it requires physiotherapy. Similar is the case of 1-year-old child with a diagnosis of HIV. She also was picked up very early, but the parents brought her only after 9 months of age. Then the child had no visual interest, not fixing or following light. We started vision stimulation activities, but was not responding. Then it was detected as severe seizure disorders. I was admitted, treated in the pediatric department. But the mother is very young and she's very cooperative. She's very hardworking. So she brought the child for all the follow-ups and did all the exercises. So at 2 years, we have a visually active child. But now she looks so picture perfect at 2 years, but she has some speech issues and some behavioral problems which are being taken care of in the REIC. So this is the message I would like all of you to take home. Early identification of the disease, early intervention always gives you a better outcome. But any child detected at any time deserves a chance at the intervention activities. And the parental counseling and support is very important. Big thanks to our REIC team.
Thank you, Dr. Sujata, for that wonderful presentation. She is doing a very good job in the government sector. It is not that very easy task to run a clinic in a government setup. And Dr. Geeta, our chief instructor, unfortunately, she couldn't come today. She is also doing a fantastic job in the government sector at Palakkad for the last 5 to 6 years. She is running a very good CVA clinic. I think she is the first one to start a CVA clinic, especially in a government sector. A big round applause to them. And now, next we move on to our chief talk of today. That is by Dr. Sandra Ganesh. She doesn't require any introduction. She is a well-known pediatric ophthalmologist and she is doing so many works in CVA. Over to you, ma'am.
Thank you so much to Dr. Geeta and the organizers for giving me this opportunity. And we have been listening to very good and fantastic talks on CVI, both evaluations and interventions. So, as you know, I think CVI is emerging as a leading cause of visual disability, much more than even retinopathy of prematurity. I think it's around 30% now of all visual impairment in the 0 to 1 year age group. So I think you have got a general idea about the interventions by the previous speakers. So the general principles of intervention will be, first, in an older child, you prepare the child. Like, for example, try to follow a routine. Like, this is true of any visual impairment, because the child may be able to anticipate what activity you are going to do next. So if the daily activities has a certain routine, then the therapy is much better. Posture. Like for children with cerebral palsy, most often like cerebral palsy associated with CVI. So we need to give a adequate posture support. For example, if the child is severely hypotonic and you are forcing the child to sit, then all the energy goes in trying to sit. So the child will not be able to keep the head up, and then the child will not concentrate on the therapy session. So you will have to give a proper posture as a chair where you can give a support and also give a neck support if needed, and then you start the therapy for the vision. So then descriptive language, like when you are trying to talk to an older child, like use a descriptive language like the radio language they will say. Like you try to describe the scene because the child may not be able to take in the message from the environment as how you are seeing. So you have to use a little more description to what a normally sighted child would need. Enhance the facial contrast. So we saw how the testing should be, at what distance the mom should keep the child in front. But you also have to increase the contrast of the mother because otherwise the mother's face appears as a big blur. So you try to enhance the contrast. Like for example, you can use a shawl or you wear bright colored clothing, or even you can use some like makeup and all. That's what they suggest. Toys that match the threshold of vision. So you don't use very tiny objects to do the therapy. You have to match the threshold of vision as how you are testing with the Lia paddles or the preferential acuity, so that size of all the material should be matching that. Otherwise, the child is going to lose interest. Use simple background as far as possible, and when the child's vision is poor but the child is good in hearing or touch and other things, so you have to rope in the other senses. Try to do a multisensory stimulation. But sometimes that can not be, sometimes the child can get averse to hearing loud sounds also. So you need to do that on a case-to-case basis. So plain background, and another thing is the refraction. So the refraction is very important. Give the correct refraction. A small degree of myopia may not be actually needed to correct. A small astigmatism may not need to correct because the child finds very difficult to wear the glasses. But significant refractive error you need to correct. And always try to give a magnification because many of these children have accommodation issues. So you test the accommodation with a monocular estimation method, and if you are finding an accommodative response, then this may not be necessary. But if there is a lag of accommodation, then definitely you need to test. And as the previous speakers have said, you can use the plus classes, +1, +2 or +3, kept handy in the clinic and then you try to test the performance of the child. So sometimes in severe accommodation issue, it will have a magical response when you put a +3 glass. The room lighting is very important because some kids do well in brighter light, some kids do well in dim light. So by the performance of the child, the room lighting needs to be adjusted. Functional vision assessment and all is mandatory, and don't be very enthusiastic. Like the child would have booked for a 1 or 1.5 hour therapy session, but the child may not be in the mood. Like the child will be crying or the child will not be receptive at all. Try to include some break time in between the therapy session. It is very exhausting for both the therapist and the child. So just build in some play break or some rest break in between 5 or 10 minutes to again get the attention. And it's always a team approach. So try the glasses first, I already said, but also the glass, if it is a high plus frame and all, so it also acts as a peripheral blinder, like the child is not able to see beyond the glass. So that may itself help in giving a focus, and because sometimes the features of CVI also mimic ADHD. Many times we may feel like that, but this may actually be helpful to prevent that tendency of the child to not concentrate. Accommodation, I said. And simple background, ambient lighting, you always use one at a time. Like don't keep the room like this. Like you should avoid the clutter. Use simple, even in the bed sheet, you instruct the parent that it should be a simple bed sheet, not a patterned one. And way the child's toys are arranged, clothes are arranged, everything, it is important. That is why you can organize some Zoom session or something. You can even connect the parent with the home. Try to see what the home looks like, because the therapy is not only with you, also you need to see what the house and what materials they have in the house and guide them accordingly. So for example, this is a 7-year-old boy born of a full-term normal delivery and with a normal birth weight, and he had a strabismus from age of 1.5 but delay in milestones, and so the MRI has periventricular leukomalacia finding, but the visual acuity is completely normal. When you test the vision, the completely normal. but the parents are having a list of complaints, like unable to write in a 4-line notebook. So sometimes it is very difficult because the lines are also of very less contrast. Then problem in mobility. The child is bumping into others. Child has difficulty in climbing downstairs. They are not able to identify dropped objects. Difficulty in unfamiliar places. Difficulty in identifying parents. So what are all the problems, like why in spite of having a 6-6 and 6 vision, why is a child facing so many issues in the school? So this problem may happen in many preterms where we are not testing for the higher visual functions and also many of the features of CVI. So the inability to write in the 4-line notebook may have many issues, like they may be having a contrast issue, they may be having the visually guided motor aspects may be not up to the mark, and they are bumping into objects or climbing downstairs because the lower field defect. So the fields has not been assessed, only the visual acuity has been assessed. Then similarly, same reason for not finding the dropped objects. Difficulty in unfamiliar places because you have the wear pathway. Like the wear pathway is very important. Both that CVA causes dorsal stream and ventral stream abnormalities, and any of those issues can have the difficulty in finding the route and also finding the classroom. And the inability to identify the parents in a crowd may be because of crowding and simultagnosia and other features. So there are so many problems which are possible even in a child with a good visual acuity. So the thing is, you have to be very open-minded in the, so an ophthalmologist or somebody who does not have the training for CVI may miss all of these findings. So it is very important for us to spread the knowledge among our own peers and our juniors and everyone, talk more about CVI so that they can pick up these abnormalities and guide accordingly. Similarly, for lower visual field defects, simple interventions may work. One is you can use the yoke prisms, like 4 prism base down. If you give, it can bring the lower field up to certain extent. And you have a trial of, like you have the trial of +1, +2, +3. You can also have a trial yoke prism where the make the child wear it, and then you can ask them to climb the downstairs or pick up or have some objects on the floor and ask them to navigate it in your clinic. So you can try those. And these type of shoes which have the illumination or sound guided, can use that. And for the notebooks, you can have like reading guide so that the child blocks out the other areas. And also you need to tell you have to give an intimation to the school that they may not be able to write in the classical 4-line notebook. Either you have to darken all the notebook or you have to make special notebooks for the child. So the teacher has to understand these aspects also. The classroom seating may also be very important, and more time may be needed. So the visual array has to be simplified. The child may need to move closer to the background, not only because they are not able to see, but it also helps in gaining the attention. They can block out the other aspects of the classroom which are visually distracting. So as close to the blackboard is ideal. So coming to another example, a 11-year-old girl with poor eye contact, repetitive behavior, poor academic performance, poor attention, uncomfortable around moving stimuli in class. So it can be CVI can be totally missed with this. It can be towards autism or towards learning disability or something like that. So sometimes the demarcation is not very clear. All the examples of the low functioning CVI that we saw coming in with the classical history may be recognized, but higher function deficits, we are just at the tip of the iceberg. Many of them may be actually sitting in the pediatrician or developmental pediatricians area, where their diagnosis of CVI may be totally missed. So the diagnosis actually was autism spectrum, but when they came, you actually see that the child had some perinatal problem also. And so autism, sometimes we just diagnose by offhand. They need to have the specific evaluation done by somebody eligible for that, and then they have to come to the diagnosis of autism spectrum. Both may even coexist also. So uncomfortable around traffic, fast moving animals, this all happens even CVI, because Again, the simultagnosia, the child may be seeing moving objects better or they may be seeing non-moving objects better. And everything comes together, again it is difficult. Fast moving small animals in playground, like in a playground area of the school, so many children are together. So there again the child may find a lot of difficulties. So motion perception, they have impaired saccades and pursuits. So that may have contribute to all these difficulties. So around running children and crowded area, which is classically a school environment, they may be totally uncomfortable. Moving balls, so they prefer slower. So if you look at the normal cartoon, even what is being played, it is very sometimes fast. Whatever the cartoons the children are seeing now, if something is slow, they are not interested in it anymore. But these children will not like that at all. So because they cannot understand it. And trouble with facial expressions already we said. So that is why I said we have to go for more of a descriptive language. Most of the human communication is non-verbal. We try to judge the other person's face, body language, and then we see what we need to talk, or sometimes many of their perceptions are non-visual. But when the child has CVI or some visual disability, then this whole thing is not there. So how we have to talk to such an individual is, if they are having difficulty with it, one thing is with good visual acuity, they may be again unable to recognize the emotion. That is one part. Or they may be not able to seeing the face. So it can be both the thing. So what is that we need to judge? Otherwise what happens is they are branded and they become aloof and they find it very uncomfortable to move in any social gathering. Even the parents, sometimes they do not take them to any social gathering because of this issue. They feel very sometimes apprehensive as to how the child is going to react in such a situation. So the whole family needs to come together on that aspect. That also we need to counsel the parent that you cannot hide your child till they become normal. They'll have to move along with the extended family and others. So another example, hydrocephalus, 6 years old, post-VP shunt, delayed milestones, also has hemiparesis, seizures, studies in a special school. And the parents say that he walks around but he cannot see most of the time. Okay, so what does it mean? The functional vision is totally different from what we are assessing. Okay, the functional, with a very poor vision also, the child may be able to function very well. So do not underestimate the visual capacities of any child. And the only problem here is pale disc. So you need to look at the contrast of the materials presented. So you always use a supra-threshold type of stimulus whenever you expect poor contrast or poor visual acuity or both together. And you can use these guides like the cane for the training needs to start from very early onwards. But nowadays we have different, if that is difficult, you can make the normal toys which the child uses for such an approach. And inferior field will decide the mobility. If they are not able to see, the child not getting the milestone of walking may be because of the inferior field deficit. So that part you need to remember. So communicable distance, that's important. Then again, this is also similar. The child, 6 months old baby, complain of not able to see the mom's face, not fixing or following light, not recognizing mother's face, on treatment. So these are the kind of kids that we get usually for the interventions. And so the visual acuity, you have to measure all the visual functions as previously stated. So initially this is over 9 years. So the mother became the therapist in this situation. She started coming to the clinic. Unfortunately, this video is not playing. But what the story is like, over a period of almost 7 to 9 years, the child had gained many of these milestones. They are able to walks with minimal support, differentiate objects, identifies colors, expresses preferences, identifies a person. So they have come a long way. But it is mainly because of the support of the family and the mother who had decided to study on early intervention and actually become a therapist along with the people who are already there. So the ambient lenses, sometimes you may need to use some filters to improve the contrast or colors. Then sensory integration, augmented communication like touch with sight. sound with something. So like that, if you augment, like many of these applications are available in the games on the iPad and all. We have a lot of applications now which can integrate some touch with sighted therapies which we can use. So the Vikas app was developed by the Arvind Madurai team, where they had put in like simple tasks like fixation to mirror, visual closure, figure ground, visual neglect. So all the higher function tests are there in the app, but this is not like some freely available. I think you have to contact Dr. Sahitya if you need access to this testing method. But now they are working on a new one called Percepto app, which will soon be available. The idea is to spread it in the community, like anybody who is coming in contact with the child, like even the immunization people, anybody, pediatrician, if they are having doubt, they can run it, and then they can have like some degree of, with some degree of surety, they will be able to diagnose CVI, and it will also give idea regarding some interventions. So that is the Perceptive app which is going to come. Smart vision glasses in higher function kids, or like the kids who are having very poor vision but with other senses intact, they can use the smart vision glasses, which will give a guide for navigation, people identification of currency, reading, like it will take a photo and it will have it will translate to the Indian languages. So those kind of possibilities are there. The ones which are available abroad are very expensive as compared to this. I think the cost comes around 30 to 40,000, something like that. But if the child is very motivated and high functioning, then this can be tried also, even adults. So many times we have clubbed along with the philanthropists and certain Lions Club and all, who have Rotary, who have distributed these to the patients. Virtual reality again can come in a big way in training, because virtual reality with a headset will block out the other senses, and can be used for vision acuity testing, can be used for field testing, can be used for therapy also in certain children, not all children. So online vision therapy sessions are always useful, because the child is not practical for the child to come in every day. So in between, the child family needs a support, or sometimes to get the compliance, you can connect online and see whether they are following whatever you have told them, and where to schedule the next appointment and all. You can do a hybrid with offline and online sessions. And also you will be able to see the home of the child. So cross disability, like CVA is has association with many other disabilities. So like it can be coexisting with autism, ADHD, Down, cerebral palsy. So you need to be aware of that also. And yeah, so certain cases neuroimaging, may add some diagnostic value, but it may not correlate with the severity of CVI. So don't look at the MRI and say that, okay, this case nothing can be done. So it is not like that. It will just give additional information. It will say which areas are affected, so you can test for those areas specifically. And see, the visual plasticity, it's variable, very variable, but the sooner you start, the better it is. So it is better to tell the NICU staff onwards. Like if they are having some perinatal insult, all these children need to see not only ROP, but any perinatal insult, even without ROP or resolved ROP, need to see the pediatrician. So this is the summary. Thank you.
Thank you, Sandra ma'am, for that wonderful presentation. It's very happy to know that these things are happening in our country in a very splendid manner. And she explained everything in a very lucid manner. Thank you so much, ma'am. Kindly appreciate this memento from our side. Any questions to Dr. Sandra?